Hello, everyone, and welcome back. We have another interview for you this evening. Today, I'm delighted to be joined by Mr. Brandon Smith, who is a fourth year medical student at King's College London, currently intercalating his PhD. So, today, we're going to be talking about Bran's journey so far. I think we'd like to talk a little bit about the Brain Book initiative that I know you've been part of. As you can see from your background, DIY engineering, how all this stuff fits into medicine, and doing a PhD during your studies. Hello, Bran.
Hello, thank you for having me.
So, Bran, I think it's probably easiest just to start. Do you want to give us a quick kind of 2 minute rundown on who you are and why should we care?
Of course, okay. So I'm Bran. I'm a intercalating, as you said, intercalating medical student, second time round. I'm doing an intercalating PhD in neurosurgery, focusing on traumatic brain injury up here in Cambridge. I suppose that's it, really. See from the background, a lot of it is fairly DIY, a lot of electronics, bit of engineering. Um, it's basically a big hodgepodge of science, really. I suppose is the best way of explaining it. And yeah, that's me.
Cool. Okay. I mean, even from that, I've got a number of questions. So you said second time around,
Yes.
intercalating. So what was the first one?
Well, I suppose the first one was a BSc in anatomy, so sort of like just basically being a perpetual student. So I did my first BSc in anatomy at King's back in I say back in 2018, so just over a year ago now. Yeah.
Okay, so for those who might not be familiar with the idea of what intercalating actually is, and let alone who they might not know the utility of why someone might choose to intercalate or what the process actually involves. Just to be clear, did you go to medicine straight after your A levels? Is that correct?
So I had a gap year straight after my A levels to go and work and just sort of build up on my grades. Because I think my first round of A level grades, I just didn't want to submit them, put them in the UKCAT system. So took a gap year, did some work, a lot of healthcare assistant kind of work, and then straight from there, straight into King's. That's it, really. Not really glamorous.
Cool. So then you get your place at King's and you do, I guess, the first couple of years of medical school, and then is it the chance to intercalate?
Yeah, exactly. So I did 2 years of preclinical study, so just your typical undergraduate. It was at the time 5 year medicine. Now all the programs I think have changed to a more 6 years. So most programs I think now have this intercalation year. So as I said, I did mine after 2 years. So before clinics, I thought, right, let's do a bit more science. So I took on anatomy. Absolutely loved it. Loved the research. Loved all the modules. Very self-selected at King's. You sort of have a big module bank. You just pick what you want, get the credits. So I did that before doing the first year of clinical studies, and then intercalated again, and that's where I am.
So I'm interested to learn a bit more about this because the medical program that I'm on, with it being a graduate entry medicine course, it's one of those things where you technically do have the option to intercalate a master's between the preclinical and clinical years, but I feel like because a lot of graduate entry courses are designed around throughput, we want to retrain
Yeah.
people as doctors. It's not ever really discussed with you, the idea that you can intercalate, and I get the feeling that they don't really want people doing it.
Yeah, yeah. I mean,
But
it's a really big strange one. The graduate courses. I mean, from what I hear, I know that they're very throughput, but a lot just seem like a compressed version of the standard program. They still do the same stuff, same preclinical science. Um, yeah, I mean, it's a really strange one. The graduate entry the schemes. I mean, you probably know more about it, but they do just seem they're just high intensity, same material. So I can see why stopping that to go to a master's might be frowned upon, but I think it's people are doing it more and more. They're not really seeing this medicine as something to be done in 5 or 6 years anymore.
sure, well, but this is what raises the questions because I feel like increasingly, at the same time, as you say with King's, we're seeing the undergraduate courses are very much embracing the idea that I have some theories. Is this to do with FPAS, UKFPO scores? Is this to do with rankings? Is this, the reasons why medical schools might want everyone intercalating is another question. But ultimately, so you did your BSc in anatomy before starting your clinical year studies. Was that for any particular reason? Why anatomy?
So I think anatomy, really, I just thought it's nice in general. I'm not going to get too tied down in something really specific. The goal has always been surgery. Even before medical school, it's always been almost like a stepping stone. It's for surgery, in a sense. That's the reason for that is just, it's just always been an interest, since young. So it's always been that logical step to do something like anatomy. The first 2 years of my sort of preclinical studies at King's, we had a big, heavy dissection component, lots of anatomy, everything from upper limb, lower limb, thorax and abdomen. And I thought I just wanted a bit more of that, but a bit more detail, more of the surgical anatomy, more of the approaches, rather than just here's the body. It's rather how do you get to that structure inside the body, in a sort of a safe way, neurovascular structures and things like that.
So I'm going to stop you there really quickly, because this is, we've both obviously, I know, been involved with anatomy education work before.
Yeah.
And I think that particularly those out there, if you're applying to medical school or you are trying to decide which medical school you might want to go to, the difference between clinical anatomy and surgical anatomy is actually not a distinction that many people are aware of. So is that something, do you maybe want to give us your thoughts on the differences there, the utility for...
Well, yeah, I suppose that's all reflected in the module choices, really. So we have things like advanced human anatomy that would cover down to the really small structures. But then you'd also have the surgical anatomy. So it's things like we learn about different approaches for different specialties. Things like incisions, why incisions go certain ways, and what structures you can access through that way, or minimal surgery, minimally invasive, I suppose, and things like that. So there does seem to be a huge difference between clinical anatomy and sort of surgical anatomy, and then there's big overlap. But clinical anatomy, it purely seemed like it had a medical focus, obviously, in clinical anatomy. Surgical was more almost procedural in a sense.
The value, or the only reason I'm asking, and this is the context, just so everyone, particularly those of you applying out there or in your preclinical years, there is very much a difference between understanding the anatomy that you always will need to understand for your diagnosis, for your procedures. Every medical student needs to have a broad understanding of the anatomy of the human body, because it's all rooted in our embryology and our disease process and so on. But surgical anatomy and platforms tailored towards surgical anatomy are, as the name suggests, more for surgeons, but the way you do that training can be very different.
Yeah, exactly. It's like clinical anatomy is finding out what's wrong as best you can, and I suppose surgical anatomy is how you can fix what's wrong, in a sense.
I just thought it was a useful distinction for those listening at home. Okay, so you've now done your anatomy, you're hopefully satisfied with it. You, I guess, do a couple of clinical years, or a year and a bit, and then the opportunity comes to intercalate again. So let's start, I guess, with why did you decide to do a PhD and extend your medical training even further?
It's a tough one. I'm still not 100% sure. But I suppose it's many, many reasons. I can't really put it down to one reason. I suppose good timing is one reason. Second is the availability. PhD programs are a bit different from undergraduate degrees in terms of fact. It's very, you start in September, October, you do it for a year and then you go back. PhDs, so many things you have to get in order. You have to get funding in order. You have to get the supervisory team in order. So supervisors, advisors, external, supervisors, the lend assistants. You've got to get a project as well. The project has to span 3 years, and you have to demonstrate that. So it's getting a lot. It has to be in order, I suppose, in order to do that. So fortunately, just through purely by chance, just for the work I was doing at the time that started in my BSc year, and then in the first year of clinical medicine, just sort of on neurosurgery. I mean, I've always been interested in neurosurgery as well, but just from that year, managed to make contacts and get in discussions with different people from different fields. There was these topics that seemed like, grab this now because it won't be around in 5 years' time, because it is now. It was really getting the stars to align, I suppose, and that's why I sort of grabbed it now. I don't think it's not really too common, I don't think, to just intercalate a PhD. I mean, it definitely surprised all the funding, student finance, for example, of being able to do it, because there's always that, can you intercalate in a degree that's sort of worth more than medicine? Because you can only get funding, sort of, I suppose what's the word, like procedurally, you can't get funding for a lower degree after doing a higher degree.
Yeah, of course, yeah.
So there's always that, that sort of almost politics involved in it as well, and all the policies and things. So it really was it almost seemed like a perfect opportunity. And so I thought, I just apply and see what happens. And then, lo and behold, managed to grab this most ideal opportunity.
Are you able to, are you at liberty to discuss the type of work that you're doing? I understand that it can be quite sensitive.
Of course, no, of course. I try and disseminate as much as possible about the theories and the works we're trying to do. So my primary focus is on traumatic brain injury, and particularly how it's followed up after the patient's discharged, with a primary focus on like lower middle income countries, or LMICs.
So very, very quickly, for the boys and girls at home, what do you mean by traumatic brain injury?
So traumatic brain injury is literally any form of head injury. It overlaps with the term neurotrauma, which also includes spinal cord injury. But my focus is particularly on any injuries to the brain as a result of any form of trauma. I think that's the best way I could probably explain it.
So to be clear again, just to make this distinction as clear as possible, someone who has, say, an intracranial bleed, say a stroke or something, that was not preceded by them hitting their head on something, or having something hit their head.
Yeah, that's not covered. It's anything purely by a traumatic cause. So falls, road traffic accidents, anything like that. Okay. There is an overlap in the research and literature with regards to strokes and things, but it's purely the neurosurgical field that my focus is on.
Cool. Please continue.
So, I suppose following on from that, the looking long-term follow-up is the main goal. So anything that happens, I mean, we define long-term as anything from the point of discharge, because long-term follow-up completely varies depending on what country you're in, and sometimes it depends, on what area of the country you're in. So we're looking at countries like Pakistan, like Myanmar, Zambia, and places like that. And we're basically trying to see what the current methods of follow-up are. So we're doing, it's a mixed methods project. So we're doing, part of it is qualitative and part of it will be quantitative. And we're trying to essentially come up with solutions to better gain those long-term outcomes, worldwide in a sense. And just
again, very quickly to interject, just because I'm just trying to be conscious that not everyone will be familiar with these terms. So, what is quantitative and qualitative data?
Well, so really, really simply, qualitative data will be interviews and things like that, looking into the themes, looking at what they're saying. So their own perspectives, their own opinions, and then quantitative will be numbers. So in the sense of this project, we're going to be interviewing physicians who've had experience in neurotrauma, seeing how they follow up their patients, if at all, see what their perspective of the usefulness of following up patients long term is. And then after that, we'll develop a solutions based on what we're finding. So we're sort of saying, if your patients are better followed up by email or letter, how can we help you sort of do that and work with us, and we can develop solutions together. And then eventually we'll get to a stage where we have a service that we developed in-house, that will enable us to better follow up. So whether it's things like telephone or text message or email, anything technological, because we think that's, well, our current understanding is that's the best way to reach people. So the biggest problem with long-term follow-up in these countries is that after the patient gets discharged, they're often lost. Perhaps they've travelled thousands of kilometres to get there for this surgery. It's very hard for them to come back, things like follow-up appointments. So we never really know what happens afterwards. So we're just going to try and develop some form of solution, technological or not, that will help facilitate that better. And sort of we can begin to understand the bigger picture.
Excellent. So again, it seems like a very strange question, but I think it will probably help complete the picture. Is why are you interested in following someone up at all? You know, say they come into hospital, they have I don't know, they've got a broken skull, something's hit them, the neurosurgeons come in and fix it, they maybe have a bit of plastic surgery, you know, they're functionally fit and well, you send them away. Why are you interested in following them up?
Well, I suppose that neurotrauma or traumatic brain injury really has a big global burden, you know, a socioeconomic, big burden. I mean, there's around 1,000 cases per 100,000 population per year. So it's quite a big number.
About 1%.
Yeah. So it's a really big number, and in terms of the effect of the trauma, I mean, it depends on the severity. But depending on the injury, the patient will obviously impact their families hugely, regardless of the level. But in terms of the burden, I mean, it economically costs from the management of these traumas around about $400 billion US dollars per year. It's just neurotrauma for all the costs, direct and indirect. So there's costs on the family, such as, you know, if that person is unable to work and obviously provide funds for the family, that's a big impact. You know, it costs the hospital to treat the patient, which is a big impact. So it's a really big, a global socioeconomic concern. So it's really important to understand further, because I mean, we say it's 950 or 1,000 cases, you know, per 100,000 per year, but that might be underestimated because we don't know the true extent of the injuries after they get discharged. So I guess it's trying to understand the problem before identifying the solutions, in a sense.
Amazing. So to move on to my kind of next set of questions, if that's all right, I guess we maybe need to talk about neurosurgery then, more as a field. So presumably you want to, from what you said, sound like you want to do a career in neurosurgery. Do you feel that this PhD and the associated research and so on and so forth, is that going to be significantly helpful for you?
I hope so. I mean, we mentioned FPAS points earlier. Having already have a bachelor's degree already intercalated, I don't think it's worth much in terms of FPAS points doing this. I think maybe 1 or 2 extra points.
Yeah.
For 3 years of work, that's or 3, potentially 4 years of work. That's quite an investment. I think it's more the things you do while you're doing your PhD is, you know, things like the connections, the opportunities to do different research, to go on different courses, and to sort of build up that almost that research portfolio, that skills portfolio, and just be more sure in a sense. So rather than rushing into and then, you know, think, this specialty might not be for me, it's an opportunity to get really a well-rounded experience of what neurosurgery is actually like worldwide, which I think is you know, fundamental importance to understand and really be passionate about what you're going to go into.
Yeah.
Because I mean, it's medicine is one of those things that's very almost every move or every project you take on, it counts in some way or another. It's not just for points, but just in terms of time available. I mean, as medical students, I think we're blessed with a big amount of free time, or at least a big amount of sort of reserve, you know, leftover energy that we might have at the end of the day.
Yeah.
It's a bit different from shadowing versus actually. I mean, from my clinical years experience, just being on the wards and doing things. I mean, I always think home and just think, oh, gosh, I don't know how I could ever go home and start writing papers. So I think it's almost that giving myself more availability time-wise, I suppose, to do the things research-wise that I've wanted to do from sort of day one. Yeah, that's I suppose one of the benefits.
That's a really interesting answer, and I think as we jumped on the call before, we were talking a bit about med Twitter and the kind of online these
Yes.
communities that come with medicine and medical Instagram of which both part and neurosurgery has a particular reputation, not only for being very difficult to get into, the surgeons unfortunately for not being particularly nice. I think that's fair to say, whether it's true or not. Neurosurgeons don't have, I don't think, the best reputation amongst their medical colleagues.
Yeah.
And the training itself for being fairly brutal. So I think these are really important. What you just said about being sure about what you're committing to and getting the exposure is really important. Let's talk about time away from medicine then, because I've just come from a 3-month break in my medical training owing to the coronavirus situation. And I must admit, when I came back onto the wards, having not cannulated a patient in 6 months, I was thinking, how am I going to, I can't remember anything. How am I going to... I was wondering if you were feeling any pressure or lack of exposure due to this break in training.
Yeah, I mean, that was one of the biggest sort of things I had to justify, not only to myself, but to everybody who had sort of a vested interest in what I was about to do is that factor of de-skilling. I mean, the problem is with de-skilling, I think people think it's more worse than it is. I mean, in terms of the skills that I've gained over the years, it's not exactly like it's going to be a full-on procedure start to finish. It'd be something like CPR, cannulation, suturing, catheterization, things like that. Skills that I think, okay, they're obviously hugely important. Run of the mill day-to-day life for sort of foundation doctors and above. But I'm also thinking they're easily, I managed to get them in sort of 2 or 3 years, but that's from scratch. That's from from being a sort of naive 18, 19-year-old with no sort of any form of manual dexterity whatsoever, to just practicing. But I suppose in terms of the amount of hours spent, it's not like I spent 3 years every day practicing. It might have been, perhaps a week of doing it, and then that was it. So I think they could easily be attained again, but it's not. It's almost muscle memory in a sense.
Of course.
I mean, suturing, I haven't done it in a time, but picking up like a piece of, some suture and some needle holders the other day, and you do sort of find it sort of comes back naturally. It's sort of getting that last little, finessing, the final touches that's really what I'll have to try and regain.
Yeah.
I mean, CPR is CPR. It will stay with you. I mean, in terms of knowledge, I think it's probably my more major concern.
Yeah, let's that's definitely worth talking about, because I was talking about this with someone the other day, and unfortunately, certainly with the final exams, because we're preparing for our finals right now, much more than ever approaching finals, I get the feeling that finals are simply a case of cranking 6,000 Anki cards a day.
Yeah.
Until you can learn everything by pattern recognition, because that's what these exams lend themselves to.
Yeah.
Obviously, it's somewhat unlikely you're going to be doing that during your PhD, because the finishing line is so far in the distance.
Yeah. Well.
So what's your feeling on that?
I mean, I have all the Anki cards and the Anki decks. I mean, I haven't touched them since starting this, because there's always been something else to do rather than just sit down and just. I suppose I'm almost excited to learn again, in a sense. Now it's not for an exam. It's quite nice to do it for personal interest. I haven't done it as of yet, because it's just been a busy year so far. But it almost it seems less daunting in a way to pick up a textbook. Are you more motivated to do so, as for the personal interest? In terms of finals, I mean, it probably would be a good idea to start thinking about preparing in the next few years and just sort of get ready and just get back into the mindset of learning and picking up the knowledge I had before. But yeah, I mean, in terms of the game plan, I suppose it will be a case of eventually having to pick up the Anki decks and slowly build back up, rather than just be here's your PhD is done, here's your 12,000 card Anki deck for you to start cramming. Yeah, no, it's gonna be interesting. I think I have to wait until the time comes to properly see. I mean, I haven't picked up the cheese and onion, the Oxford Handbook in a while. But I can imagine when I do it'll be a familiar face. Won't be as daunting of a face. And it'd be nice to actually read it, I think, rather than just look at the words and commit them to memory and not truly understand what I'm talking about. Because there is a patient at the end of these pictures and of these sentences. So it would be nice to actually appreciate it more, I think.
I think I've maybe done you a disservice by disconnecting your PhD from medicine, which of course isn't the case. You're doing a clinical PhD.
Yes, yeah.
So there will, I guess, particularly as far as the neurology and the neurosurgery, you'll be learning by osmosis for the next 4 years.
Yeah. I mean, well, that is the case, but again, being just on neurotrauma is probably like 2 or 3 pages in a big manual of 400 pages that we're expected to know, or at least know most of. But I think the exams will change I've got, until my finals, it's how many years is that? Potentially 4, 5, 6 years down the line. I mean, I think I have the UK's the new exam will be in place by the time I finish. So it's going to be interesting. I mean, there might be some more standardization. It might be more of a nicer return than expected, in a sense.
Yeah, again, for those, I realise that many people probably won't know of what we're referring to, the UK MLE. So, just very quickly, for those of you out there who might be quite surprised to know that the UK medical education system has no standardised set of exams for medical schools anywhere. The final exams that I sit at Warwick, that Bran sits at King's, that someone else might sit at Manchester, are completely different. And I think it's fair to say they try to standardise them from central question banks and things like that, but there is certainly disparity. So in the next few years, we're expecting to see the introduction of this standardised exit exam for medical school. Which you say, if it's several years down the line for you, will probably be in place. Yeah,
I mean, it looks like it's the sensible decision in a sense. I've read through a very quick, almost like a white paper from the GMC the other day, just sort of listing what it will be and what it will sort of entail. It does seem very well-rounded. It does seem very, like, these curriculums can be sort of narrowed and refined, and it would be nice to have everybody's efforts focused on one curriculum, rather than everybody delivering their own. And sort of, I mean, at the end of the year, there's always this thing about, these exams are harder than those exams in these different universities, and it's just like, especially in terms of things like the SJT, which I assume will have to remain in some element or another. The situational judgment test, I suppose, for those not familiar. So it's going to be interesting to see I don't think many people know of it yet, really, because those who know of it are sort of happy that it's not going to affect them. And
very much.
And I think those who it will affect are probably too early to fully appreciate what it is.
Yeah.
So, yeah.
I do wonder, part of me wonders whether we will see it begin to influence specialty selection, in line with what we see in the US. So again, for those at home, currently your chances of matching into the specialty of your choice, so if you want to do something like neurosurgery or just surgery in general over there, your chances of being accepted onto a program are very much tied to how well you do in medical school, in the various step exams. In the UK, it's almost completely disconnected. How well you do in medical school has, well, little to no effect.
Perhaps if you include the sort of the academic foundation programs, maybe it might be a bit of a connection in terms of you normally do an AFP position with the specialty you want to go into in mind, perhaps sometimes. You normally choose one of your rotations to be in that. Perhaps you might even spend your AFP, your research component, looking into that specialty. Maybe. I suppose, your finals will sort of depend whether you get the AFP. That might be that sort of, but it's very, again, as you say, very disconnected, very not straightforward, not as the US programs.
Yeah. Well, and then the last thing I guess I'm going to ask you about is managing your time, because as a medical student, I'm currently in the midst of my acute medicine block. I'm pretty rigidly timetabled, and I know what I'm going to be doing any given day of the week, any hour of those days. As a PhD student, what's your time management like?
It's a big difference. It's a really big difference. I mean, a lot of people say that the BSc year is like the gap year of medicine in a sense. So you do your own degree, and it's sort of very laid back in terms of there's no 9 to 5 Monday to Friday anymore. A PhD is almost less organized and structured than that. I mean, for example, mine will completely vary. Mine's a completely research-based PhD program. There's no talk component to it whatsoever. No lectures, no nothing. I mean, my contact hours are the ones I set, which is
dangerous.
It's very it can be very dangerous, and they do often say that the first year of a PhD is just it's just very, very, very chilled. I mean, it has been relaxed in some respects in terms that there's a lot of waiting involved. You've got to wait for ethics. You've got to wait for different people to get back to you regarding whether this avenue is possible and whether this one isn't. So it is very much you do everything off your own back. In terms of organization, though, I feel like I've got better at it. I mean, you know what's expected of you. You have deadlines. It's almost a sense that if someone's asked you to do something, you're probably too late in terms of you should have been in last week.
Right, I see.
For things like, and there's a big, heavy research component, obviously, with lots of different publications have their own deadlines, things like that. I mean, my research group itself has its own deadlines. We have to obviously have a certain amount of output per year.
Oh, so I see. So even though, your PhD as such presumably operates to some sort of plan that you've set for yourself, the research group to which you belong has its own plan.
Yeah, it does. I mean, my research group is purely on neurotrauma, and it covers everything from policies. It covers everything from prevention to management to investigations. And my research form is almost a very small strand of that in terms of the innovation side of things and the long-term follow-up, the data and the long-term outcomes behind it. But it really is depending on the PhD. I mean, some will have sort of labs Monday to Friday, 9 till 6, perhaps even, sometimes 7 till 6, 7 till 7, completely depending on what you do. But yeah, they're very unique experiences, I suppose. I don't suppose any will be the same as mine or ever again after this. But it's you're not really a student, I suppose, saying a PhD. You're very much seen as which is nice, obviously, as a member of the team, as a clinical member of the team, and you have expectations, and you've got to meet them. I've managed to get myself more organized in terms of setting myself deadlines that are realistic, which is hugely important. I suppose medicine was a bit more, here's your rota, be there on time.
Yeah, do it.
Now it's like, I've got to make my rota and I've got to be there on time. So yeah, it's been a great experience so far. We're loving every moment of it. And more years ahead, I suppose. I think now is a time now all the ethics are in. Now is the time to really start cracking on.
Definitely, and I think, particularly for a research-heavy specialty like neurosurgery, all of these other, as you said before, all of these other things will very much help in shuttling that career progress forward. Very cool. So I guess the last question that I'll ask before letting you back to your Sunday evening is if other people, if someone else during their medical school experience decides, not just for neurosurgery, but they might want to do a PhD in, ethics or medical education or gender identity or any of these topics that we're seeing more and more funding for. What are some ways that they might be able to investigate or go about that?
I suppose plain and simply is just asking. I mean, just not being afraid to knock on doors and to answer and to send out emails. I mean, very, very, very fortunate in terms of I managed to knock on the right door at the right time and it opened. But it just being not afraid to ask. It can never go wrong by asking. It truly never go wrong. You could have it. I mean, if you ask and they say no, they'll probably redirect you to a colleague who might have an idea. I don't think anything can come wrong from asking. So always ask. Never, I suppose never take no for an answer. In terms of some ways, it's like it really depends on what your medical school will allow you to do. But I suppose if you have a sound reason for it and you've got a plan ahead that's not naive and it's well thought through, I don't think you can ever go wrong. Really, it's a very tailor-made experience medicine. You choose completely what you want to do. It's almost complete autonomy with what you want to do. If you have an idea, chances are you probably can do it.
Yeah.
It's just finding a team as well, I suppose, is incredibly important. Anybody who wants to get involved in research is never done by an individual. Well, not anymore. It's so important to be part of a team who has a shared interest. So find a team, don't be afraid to ask, and just go from there.
Amazing. Well, Mr. Brandon Smith, ladies and gentlemen listening at home, are you happy to be contacted?
Of course.
Yeah. What's the best way for people, if they have any questions about what's going on? Do you have social media that they can follow?
Instagram, Twitter, or email, even email. My handles on everything are Bran G Smith, and my email is I remember what email is, hi@bran.gs.
Excellent. Excellent. Well, thank you very much. We will leave links to everything relevant in the description below. And once again, thank you for coming on.
Thank you for having me.
Not a problem. Take care.